speaking on vision therapy. What's new in amblyopia?
So let's see a couple of truth and myths that we have. We have been trying to understand amblyopia for past 300 years, but then what Mark Twain said is not the thing that I don't know that are the problem. The problem is the things that I thought that were true, which are not. And I feel for amblyopia that's the most important statement, because we feel we know a lot about amblyopia, we feel whatever we are doing in amblyopia is perfectly right. Even today, I come across patients who tell me that I've been told that after 10 years of age, amblyopia cannot be treated. I don't know how many of you believe in that, if amblyopia can be treated or not after 8 or 10 years of age. So, a couple of truth, there's a critical period, and after the critical period, visual acuity, binocularity and stereopsis cannot be restored. Is it true or false? Can we treat amblyopia? Can we treat neurological disorders? Can we treat all these issues after a critical period? Is there any critical period that we have? How many of you feel that it can be, there is a critical period? Okay. Yes, there is a critical period, and all of us are aware of that critical period. There's a specific period before which amblyopia cannot be treated, and a specific period after which amblyopia cannot be treated. And that is this. We cannot treat amblyopia before birth, and we cannot treat amblyopia after death. But from birth to death, there's no such critical period where amblyopia cannot be treated or any of the disorders cannot be treated. So please get it out of your heads that amblyopia can be treated only up to 10 years of age or 12 years of age. It can be treated at any time. Now, whenever we're talking of any problem, we talk in terms of the definition that defines the problem. So amblyopia has been defined classically as the Greek word, which is weak eye. It was defined in 1730 as the first clinical definition. 1720, the first treatment of occlusion came in, and I lectured in 2014, now 2022 also. The first line of treatment is occlusion, patching, and nothing else is done. I don't think there's any disease or any disorder where the treatment has lasted for almost 300 plus years and no change has taken place. Functional definition given by my good friend Dr. Kenneth Kifreda. He says functional amblyopia is a unilateral or infrequently bilateral condition in which the best corrected visual acuity is poorer than 20/20. A lot of us feel that 618 is the line, 612 is the line. What happens if a person has 6/6 in one eye and 6/9 in the other eye? Is it amblyopia or not an amblyopia? According to me, yes, it is amblyopia. So what Ken says is anything less than 20/20. In the absence of any obvious structural or pathological anomalies, but with one or more of the following conditions, and the conditions are significant anisometropia, constant unilateral iso or exotropia, significant isoametropia, significant unilateral or bilateral astigmatism, and image degradation. When we are talking of image degradation, we are talking in terms of any of the corneal anomalies or the cataract, etc., etc. But all the same, those are not the major causes. We come across hardly a few percentage which is due to cataract or corneal anomalies. Mainly it is because of either anisometropia or strabismus. So these are the two basic causes for amblyopia. Now we come across something called behavioral definition, which is behavioral and not only ocular. So we are talking in terms of a neurological definition of amblyopia. Why is there a problem with the eye? We've been talking ocular. Is there a problem with the eye? by definition, there's nothing wrong with the eye. The problem is somewhere else. Because if there's an isometropia, the brain is not able to fuse those two images which are coming from the two eyes. If there's strabismus, again the brain is not able to fuse those images. So there's a diplopia, there could be an iciconia, there could be other problems. And the problem is not because of the eyes, but the problem is because of the brain, because the brain is not able to fuse and the brain starts rejecting one of the eyes. And that's precisely what is causing amblyopia. So are we looking at eyes which are a problem or the brain which is causing a problem? Okay. So amblyopia is a primary problem due to binocular competition. There's a competition which is happening between the two eyes, and that is what is causing amblyopia. And that is not in the eyes, but ultimately the images which are fusing in your occipital cortex. To take it a little lightly, it's a binocular competition with each eye taking turns speaking to the mother. One eye becomes more dominant and starts talking to the mother and blocks the other eye. And that binocular competition keeps on increasing suppression. And that suppression keeps on increasing, and one day comes when the eye goes into amblyopia. Suppression is so high that the visual acuity starts dropping down. So suppression can be that the visual acuity could be normal in both the eyes. But here in amblyopia, the suppression is so high, the depth of suppression is so high that the visual acuity starts dropping down, and that is what we call amblyopia. So the eye, is it weak? Eye is not weak. The problem is because of suppression, which is an active process. It's an active neurological survival mechanism. Why is suppression caused? Why does the brain cause suppression? If I have an iciconia, I will not be able to move around normally. If I have diplopia, will I be able to move around normally in my visual surroundings? Not at all. So the brain comes into picture, and the brain cuts off the second image or cuts off the eye which is causing an abnormal sized image, and that is where the survival mechanism is there. So amblyopia is in the brain and not in the eye, and it is a binocular problem which is manifested monocularly. Amblyopia is not a monocular problem. We always treat amblyopia as a monocular problem where we are looking at improving visual acuity in one eye. We are not treating it as a binocular problem. So it's a binocular problem which is manifested monocularly. Lastly, we are treating a human being with amblyopia and not the eye with amblyopia. Why? All these things, where we are talking in terms of the eye movement skills, we are talking in terms of the accommodation skills, we are talking in terms of the version skills, we are also talking in terms of the perception. It could be non-motor visual perception, it could be motor visual perception. Every single thing is affected in amblyopia, and when that is affected, a human being as a whole is affected. The way he works, the way he talks, the way he walks, the way he does everything, everything is affected. So ultimately what we are treating, we are not treating an eye with amblyopia, but a human being with amblyopia. What are the treatment options? The classical treatment, we look at a full refractive correction and a patch. I said it is a binocular problem. When there is a binocular problem, if I give a full optical correction to the amblyopic eye or either of the eyes or both the eyes, am I not increasing the binocular competition? I am creating further competition. If I give a patch, I said it's a binocular problem and I am making the person monocular. What's the big idea behind it? So, we do not give full optical correction. We do not give a opaque patch. Optical correction should be provided so that the binocular competition is reduced. We reduce the binocular competition, and that is the way optical correction, the ways that we use is, just a second. Okay. We use binocular tests like Rutherford dot test, gyroscope, your test for stereopsis, all those tests, wherever you're able to gain certain amount of stereopsis, binocularity, those are the things that aid your optical prescription. Similarly, when we are doing patching, we do not use opaque occlusion. We use something called Bangerter foils, which allow the light to pass through. It cuts down the visual acuity to an extent, but induce binocularity. Again, we use a test, binocular test, so that we are able to make the person binocular and treat the person accordingly. Dr. Ramachandran mentioned that we are in a new era of neuroscience and every day more applications are being investigated for brain rehabilitation. Neuroplasticity is a reality that nobody now denies. Basic treatment behind amblyopia. We have always believed that after 8 years, 9 years, 10 years of age, we cannot treat. But then, how we got into this particular, today's definition or today's method of treating amblyopia is looking at a person who is paralyzed. Obviously the brain, certain part of the brain is dead, which has caused paralysis to the person. But physiotherapy or any other therapies that revives the function, if it can be revived, how is it happening? So what is happening in amblyopia? Again, something is not functioning appropriately. Something is sleeping, you've got to wake it up. And that's exactly what we're doing in amblyopia treatment. So we are looking at neuroplasticity. I'm just running through my slides. I see a clock which is going fast. So let's look at some of the treatment options that we do. The cells have not been destroyed. They're sleeping and ready to be woken up. How do they do it? A simple case of behavioral optometry. And how do we do that? We have to find the key. The first thing, a proper refractive correction. Second thing, a proper occlusion. Third thing, proper optometric vision therapy. These are the things which are required. Just three things. Your optical correction or the refractive correction should be based on binocular tests. We should correct or overcorrect or do whatever so that maximum amount of binocularity is achieved. Similarly, when we are looking at Bangerter foils, it is not going to occlude the eye totally. It is going to allow certain amount of light to pass through, and through that we are able to achieve certain amount of binocularity and continue with the treatment. So the refractive correction should be binocularly corrected. Similarly, the occlusion should be binocularly happening. And finally, the active vision therapy. When we are talking of active vision therapy, we are talking in terms of three things. One thing is monocular, biocular, and binocular. I'll just show you a few things. So monocular is basically improving and building up the confidence. So there are tests. Anita talked about a number of tests and number of therapy procedures by which we are able to improve the visual acuity monocularly. Establish central fixation, improve the fixation. If the fixation is eccentric, paracentral, you need to improve the fixation. So for that we have Hedinger brushes which were being used in synaptophore, but that did not give the patient a proper feedback. So we have something called macular integrity tester 2, with which a patient gets a perfect feedback as to where he is looking. And once he attains a feedback as to where he is looking, there's a very easy way in which he knows where to come to. So fixation is important. We're looking at monocular fixation in binocular field, wherein it is something like this. If you see the picture over there, there's a plain paper, and on that plain paper there are some zigzag lines with red color. Now when I use a red-green filter, red in front of right eye and green in front of left eye, what will I see? My right eye will not be able to see the red lines, so I'll see only a plain paper. The left eye will see black lines on the white paper. Am I not treating amblyopia? Am I not treating suppression? And these lines become smaller and smaller, the patterns become smaller and smaller, and I am able to treat the patient biocularly. So these are some of the things that we use. You can make your own designs, you can make any number of targets and provide therapy to the patient. Finally, binocularity. So we have different kinds of binocular therapies which are provided, and that is the one that is going to give stereopsis. Amblyopia is not improving visual acuity. If you just improve visual acuity, there is likely to be regression. But when you improve stereopsis, hardly any chance of getting a regression. So when we are looking at binocularity, improve the stereo acuity index, and then you are done with it. Okay? In summary, don't forget to treat the whole child or the adult. You are not treating amblyopia, you are treating the entire person. You also need to work on any problems in learning motor, bilateral integration, perception, etc., etc. So unless we treat everything, you are not going to treat amblyopia. So please get into that and learn the right way of treating amblyopia. So behavioral optometric vision therapy treats people, not just eyes, and it does change lives. Thank you very much. Happy to take questions.